Hello and welcome to our continuing education presentation on the quality in pharmacy and the impacts of healthcare quality measurements on medication use and the roles of the Pharmacy Quality Alliance. My name is Chris Contrabar. I currently serve as the Executive Fellow for Pharmacy Quality Alliance, and I am joined today by two of my colleagues, Lauren Kirk, who serves as the Director of Stakeholder Engagement at Pharmacy Quality Alliance, as well as Ben Shirley, who serves as the Associate Director of Performance Measurement for PQA. As far as disclosures go for the three of us, as mentioned before, we all do work for PQA, so that is an employment disclosure for us today. And then looking at our objectives here for both pharmacists as well as for technicians. So we hope that you'll find this presentation informative and that by the time that you're finished with this presentation, you'll be able to answer some questions regarding each of these objectives. So transitioning now into our content portion of the presentation, looking first at the role of healthcare quality. And we wanted to provide a high-level overview of what healthcare quality currently looks like within the United States healthcare system. And to start with, looking at a kind of complex example of what it looks like under the ACA. So back in 2010, when the ACA was put into implementation, this was published out within a number of different publications, looking at what the healthcare system currently looks like under the ACA with all the different moving parts. Really quite interesting here, something I always like to point out is trying to identify where patients are within this diagram. I'll give you a few moments to try and find them yourself before pointing them out for you. And so you'll notice along the bottom right-hand side of the screen here is where the patients are at. It's very interesting to me that, the Secretary of HHS is very large in the center here, and patients certainly are down in the right-hand corner. And really the hope, of course, within the healthcare system is that we have patient-centered care and that patients are at the front of mind in everything we do. But as you can see here, there's a lot of different aspects that impact the patient care that's delivered within the United States. It can impact the quality of care that's being provided as well. Now, with that in mind, when we think about the ACA as well, they were explicit about calling out healthcare quality as being a goal of the ACA. It specifically called out the Department of HHS, or Health and Human Services, to establish a national quality strategy. And this resulted in the triple aim being put forth within the ACA. And so the triple aim looks at the delivery of healthcare services, also patient health outcomes, and population health from those three perspectives. And if we break that down further, to the current national quality strategy, this breaks down into 6 different priorities, as we can see here, relating back again to better care, to healthy people and healthy communities, as well as affordable care. And as I look at this list of 6 here, I always like to highlight that pharmacists do have an impact on each of these 6 different aspects of the national quality strategy. When I think about making care safer, whether that's checking prescriptions either at the community pharmacy or in the hospital and health system pharmacy settings, making care safer is something that we monitor both disease state interactions as well as medication interactions and appropriate use of medications to ensure they're safe and appropriate use there. When I think about looking down towards the bottom of this list at working with communities to promote wide use of best practices to enable healthy living, I think about as a recent pharmacy graduate and the amount of curriculum pieces that were involved within the pharmacy curriculum when I graduated from South Dakota State University, and how we oftentimes would learn about the different health aspects beyond just medication use, helping enable patients to live healthier lives so that perhaps they don't have to use as many medications down the road, or that they're better able to control their disease states without the use of medications, or in complementing with the use of medications as well. So by enabling these healthy communities, again, we are, as pharmacists, really having an impact across the national quality strategy here as well. So long story short, pharmacists certainly are involved with healthcare quality and with the way that quality is delivered within the healthcare system. So why does that matter? Why does quality really matter? When we think about from a historic context of the healthcare delivery system, and I think about volume-based or fee-for-service care, when we think about that, the typical way that healthcare has been delivered, the more patients that you see, the more prescriptions that you can fill, then the more earnings you're going to have on the other end of that. So we have this volume-based system where you're paid a certain amount for seeing a patient or for filling a prescription or whatever that might look like. And we've seen a shift really now towards value-based or outcomes-based care and care delivery for the patients that we serve as well. And this is where quality comes into play, because with value, we have the value equation, which is quality, of course, over cost. And so if we can deliver higher quality care at a lesser cost, we're delivering a better value to the patients that we serve as well. And so when we look at kind of the shift towards value-based care, we have to, in order to measure the value that's being delivered, we have to be able, in order to be able to measure the quality that's delivered. So to give us an example here of what this looks like, and a more relatable example perhaps, I always like to give the example of cereal. I'm a big cereal eater in the mornings. I typically have a bowl of cereal before coming into work each day at PQA. And so when I go to the store as a recent college graduate and I'm looking at the shelf, I notice that I can get a box of Honey Nut Cheerios. And I noticed, the nutritional value on this is a big box of Honey Nut Cheerios, and that box of Honey Nut Cheerios is going to cost me $5. Seems pretty reasonable. Now, when I was in school and I would go to the store at the Hy-Vee, which was a pharmacy and a grocery store that was nearby where I lived going to school, I noticed that they had the Hy-Vee brand of Honey Nut Tastios. Different mascot that's on the box, of course, but very similar nutrition value, same size of box. Otherwise, I knew that cereal was similar tasting as well, and so it was delivering the same quality of cereal to me. But this box of cereal was only $3. And so we can see now that, again, when we're providing, similar quality of product or similar quality, in our case, of service to the patients that we serve, and we can do so at a lesser cost, then we're providing the better quality of care that's being provided within that as well. Now, if we zoom back out and relate this back to healthcare quality as a whole, we look at CMS and the different quality programs that the Center for Medicare and Medicaid Services has in place. In this slide, I really like to highlight that CMS takes quality very seriously. They have a number of different programs that come into play when it comes to quality measurement and ensuring that the quality of care being delivered to their patients and their beneficiaries is of high quality. And I always like to focus in here on the population health side of things because, of course, as you can see here, this is where Medicare Part C and Medicare Part D fall into play. And so within Medicare Part C and D, of course, there's specific quality measures, which we'll get into in just a moment as well. So we'll transition now from looking at healthcare quality from a systems level, from the U.S. healthcare system, and looking really at quality metrics. And why do we measure quality? Why is that important? And really the reason that we measure quality is because in order to improve quality, we have to be able to measure it. It's hard to improve something without knowing where we're starting and where we're trying to head. And so quality metrics really enable us to measure ourselves both, again, on how we're doing at a baseline and how we do over time with trying to improve the quality of care that we're providing. So how is a quality metric calculated? When we look at quality metrics, really this comes back just to really elementary fractions, looking at both a numerator as well as a denominator. And starting out with the denominator, this of course is the patient population that we're working with and we're trying to measure a particular service within. So that denominator comes into play. You'll notice as well in the denominator that we also have some exclusions. And these exclusions allow us to really focus in which patient population we want to come into contact with and really what we want to focus on. Perhaps say if we're only wanting to focus on patients that are diagnosed with diabetes, or even more exclusively within that, patients that are diagnosed with diabetes and are on a certain number of medications for their diabetes or other disease states. So then, of course, on the top end here, we have the numerator. And this can be what action we're trying to measure, whether that's comprehensive medication review completion rates, or whether that's the number of patients that are appropriately adherent to their medications from the pharmacy as well. So, to relate this in, again, back to a food example, you may notice a theme throughout this as well, that we certainly enjoy having food examples to try and relate this back to kind of real-life examples and relatable examples here. We'll look at M&Ms. Now, I am an SDSU graduate, and so I want to say that within a bag of M&Ms, our colors at SDSU were blue and yellow, and so at South Dakota State University, blue M&Ms are the highest quality M&Ms that we can have. So a quality bag of M&Ms to me is going to be a bag with 80% blue M&Ms or greater. So I go to the store, I get a bag of M&Ms, and of course I pull out all the bags of M&Ms, and I see that we're going to count all the M&Ms within them. And of course on the numerator here, the blue M&Ms are going to be the ones that I want to measure for quality. Is this bag of M&Ms of high quality? So I count all the bags of M&Ms. It was a pretty big bag, and so it had 100 total M&Ms within it. And of those 100 total M&Ms, 75 of those M&Ms were blue. Of course, this is fairly straightforward math here as well, and so we'll see that this is 75% of the M&Ms in this bag are blue, so I'm going to have to be writing Mars candy because this does not meet my definition of quality. Now, that said, as I start to look a little closer at these M&Ms, I notice that some of them don't have an M imprinted on them. And, I get to thinking that, wow, those might be imposter M&Ms. Perhaps there's some Skittles that accidentally got mixed in here, so I'm not even going to eat those anyway. I don't want to include them in my counts. So my exclusion criteria then becomes that no M is included on the M&Ms. So I start to go through the bag again, and we're looking at, of course, we have 100 M&Ms total in the bag, still with those 75 blue M&Ms. But I noticed that 15 of those total of the total 100 M&Ms do not have that M imprinted. And of those 15 M&Ms without the M imprinted, 5 of those M&Ms were blue. So we're going to get rid of 5 on the top and 15 on the bottom. That leaves us with 70 blue and 85 total M&Ms that we're trying to determine if this is a quality bag of M&Ms. And in fact, when I do the equation here now, we end up with 82% blue M&Ms. So wow, this was a quality bag of M&Ms after we added those exclusion criteria into play here as well. So bringing this back around to our healthcare side of things, and really looking at the pharmacy side of things here to give us a more clear example of how this impacts pharmacy and pharmacy-provided care, is looking at comprehensive medication review rates here, for example. So again, on the bottom here, we can see it's the total number of patients in a plan that qualified for CMR. And when we develop a measure like this, the qualification criteria there, the inclusion and exclusion criteria, are set within the measure itself. So those are set up front, so you know which patients you have to focus on. Again, perhaps we're looking at patients that are only on 5 or more medications because we know that that'll be our high impact patients when we complete the CMR review with them versus somebody who's only on 1, maybe 2 medications. So we start to set these exclusion criteria. It really helps us focus in on those patients. Then, of course, on the top here, we're going to have just the number of patients that in that plan that received a comprehensive medication review. So again, the denominator, we can impact that by setting those inclusion and exclusion criteria. And then the numerator, simply speaking, is from that population that qualifies, we're able to focus in on that population and complete those CMR rates to try and increase our overall quality score and quality metric that we calculate here. So finally, when we think about the different ways that we measure quality, there's 3 primary ways that quality can be measured. We'll start on the right-hand column here and work our way back. And we look at outcome-based measures. And these are really, of course, the ultimate goal of healthcare. We want to impact the outcomes that our patients achieve, whether that be 30-day readmission rates or other types of patient health outcomes that we can look to achieve within this in order to, again, decrease the overall cost of care and increase the quality of care that's being provided. Now, with outcome measures, these can be a little more difficult in order to measure just from the specific data that's needed. Perhaps we're crossing from the pharmacy over to health systems in order to achieve this data. So outcome measures, while they are the ultimate goal, can be difficult to measure at times. So working our way back here, we look at process-based measures. And these are deliveries of specific clinical services. So perhaps instead of looking at a 30-day readmission rate for an individual with a heart attack, we can say that, well, according to the evidence, a beta blocker should be prescribed after a heart attack occurs, according to the current guidelines. So therefore, we can measure how many patients were prescribed a beta blocker after their heart attack, or even further, how many patients were adherent to that beta blocker after their heart attack. So these are process-based measures that we look at. And finally, working our way back to structure from an even higher level view, looking at things that, again, we know we can put into place at the health system level or even at the provider level or organization level that we know can increase the quality of care that's being provided, but we don't inherently tie that over to the outcome necessarily. So this is things like access to electronic medical record. And so, if a facility is utilizing electronic medical record, we know that that can improve the overall quality of care being provided. And therefore, if they check that box, then they meet that level of quality that's being measured from the structure level. Now, arguably, there's a fourth level here as well that's become more and more prevalent in recent years of trying to be measured, and this is the patient experience. So going beyond just the patient outcomes to say, what was the patient's experience with their care? Do they feel that they achieved a healthier life through the care that was provided as well? So this provides, of course, the feedback on the patient experiences, and this is looking at things like patient surveys that can be done. Now, that being said, again, we talk about outcomes being difficult to measure, and patient experience can be even more difficult to measure just from the validity of the survey that has to be measured, and of course, the variability that can happen within these patients that are answering the different surveys. And with all of that background in mind, I'm now going to pass it over to my colleague Lauren Kirk to talk to us about some real-life examples of not just how quality metrics are measured, but really how they're utilized. Lauren?
Thank you, Chris. We've reviewed quite a bit of information here in the first portion of our presentation, and what we'd now like to do is contextualize it a little bit and let you know how to explain this if you were at a cocktail party. So we use a more accessible example here of Yelp. This is the restaurant reviewing platform and app that allows you to essentially assign a star ratings to your the restaurant that you ate at this past weekend. So I'm in Chicago. I'm searching for a new restaurant to eat at this coming weekend. And I go to Yelp, and I can easily see that the Girl and the Goat there is rated a 4.5 stars restaurant there. 6,319 reviews. I can see that patrons have rated this restaurant based on atmosphere, service, the quality of the food, the taste of the food. All of those elements are rated at an individual level, and all of those measurements then add up to be that cumulative average score there. Those scores then are averaged even further up into that star rating score, where we've deemed the Girl and the Goat to be a 4.5 star restaurant. Well, interestingly enough, you can do this as a consumer of healthcare, and you're able to do that when searching for a health plan for your grandmother. So 65 and older grandmother needs a new Medicare plan or needs a Medicare plan. And so you're able to find a similar type of review system online through planfinder.gov, which we'll highlight here in just a moment. But similar to Yelp, you can be looking for this plan and identify that it has a star rating score. So Best Care Health Plan here has 4 stars, or is rated as a 4-star health plan. And that score is determined by a number of different measures. We've talked about quality measures, or Chris has mentioned quality measures, and Ben will be speaking about the development of those quality measures. But those measures that have been identified to rate this health plan ultimately add up to that star rating score. That said, it was a bold ambition in establishing the Medicare Part D star ratings scores when the government established it. They intended for consumers to pursue quality or consider the quality of a healthcare plan when picking their plan. That said, when reality came across, we found that the consumers were choosing their health plans based on a number of different factors, which did include quality. But in many instances, the higher priorities were the national brand recognition, the medications that were covered under that plan, as well as the details of the premiums and the cost of the premiums. So in any sense, while quality is certainly a factor that has been calculated for each of these health plans, it in many instances has fallen to be a less higher priority when choosing a health plan for grandmother. I mentioned that these star rating scores were available to the public and to the consumer. And you would be able to find them here at medicare.gov. And there you'll be able to search through and sort through the premium details, the national brands, as well as the medications covered, and of course, be able to identify how many stars each plan has been assigned. And that again is through the Medicare Part D star rating score. So we've discussed the perspective of the star rating score for the consumer. Let's see what's in it for the health plans. The health plans have high stakes in the Medicare Part C and D star rating scores. We have two approaches that are really summarized there, one being a carrot and one being a stick. And so the carrot approach there in the orange is the quality bonus payments. So health plans that achieve 3 stars or more, or if you're a new plan, receive a quality bonus payment. So let's discuss the stick approach and how the government motivates higher quality for these health plans. The enrollment implications here. So 5-star plans or those plans that achieve 5 stars are able to enroll patients at any time during the year. Medicare enrollment is limited to about a 6-week period in the fall, traditionally, but 5-star health plans are able to recruit their members to join that health plan at any given time during the year. So imagine if you were able to advertise your product only 6 weeks of the year, and the advantage that might come with advertising that product throughout the entire year. Obviously, those health plans with a 5-star rating have higher stakes because they're able to advertise and enroll members throughout the year. For health plans that do not achieve a higher star rating score, they receive 2 elements, one being a scarlet letter from CMS. So essentially, CMS sends the members of that health plan a letter in the mail that says you are part of or receiving care from a health plan with a low star rating score and suggests courses of action to that consumer. Additionally, on planfinder.gov, there is a low performer icon assigned to that low performing plan. So when a consumer is working their way through planfinder.gov, they're able to see and identify low performing plans using that low performer icon. So what does this all mean, and how does it connect back to the Pharmacy Quality Alliance? The Pharmacy Quality Alliance was founded in 2006 with the implementation of Part D. And in that establishment of the star ratings program, the government became the largest payer for drugs in the country. At the time, they essentially said they only wanted to pay for the quality use of those medications, and at the time did not have all of the measures necessary to measure that quality use. So that's when the public-private partnership between the Centers for Medicare and Medicaid Services and PQA was formed. PQA contributed to the initial set of measures that were part of the star ratings program, and still today accounts for roughly 43% of a health plan's star rating score. So since 2006 and the establishment of the Part D star ratings program, and since PQA made our initial contribution to that program, we have very much evolved into a nonprofit quality measure organization with 3 things that have remained true and constant since our founding. That is our multi-stakeholder membership, as well as the transparent and consensus-based process that Ben will speak to here very shortly. So let's take a look at that multi-stakeholder membership. Here on slide 26, you'll see a representation of PQA's membership as a pie chart. Let's take a tour around the pie chart here and cover a few of the membership sectors and highlight some of the members that are part of those sectors. The first there is the associations, foundation, and research institutions. So that membership sector includes the professional organizations and trade associations that are representing the pharmacy profession, as well as more public health-oriented organizations. In the community pharmacy membership sector, we have the big guys that are nationally recognized, as well as smaller, more regionally based chains. Analogous to that is the health plans membership sector. We have the larger recognizable names that are providing majority of members across the country their health care, as well as the smaller, more regionally and state-based health plans that are providing care to specialty populations. One of the largest membership sectors for PQA is our health technology solutions vendors. And in that, you will find a variety of different organizations that are providing some pretty innovative solutions to the marketplace. All of these solutions are consistent in that they are providing ways and means for these companies, whether they be community pharmacies, health plans, or other. They're providing them means to improve quality within their respective operations. Included in that are some very well-established organizations, but also some pretty cool startups that are bringing, like I mentioned, some pretty innovative solutions to the marketplace. Similar in size to the health technology solutions membership sector is the membership sector with the universities and academic institutions. These are primarily schools and colleges of pharmacy. Looking at our healthcare quality and standards organizations, these organizations are similar to PQA in that they are helping to define exactly what quality is in the marketplace. Our life sciences organizations include 8 of the top 10 global pharma organizations and really work with PQA as they develop their quality strategy, understanding that as the quality of medication use increases, often and in many instances, as does the sales of their particular product. And rounding out our pie chart here are our government agencies. This includes a number of different federal agencies as well as some state-based departments of health and human services. So in summary, when looking at PQA's multi-stakeholder membership base, I think you'd be hard-pressed to find a more diverse stakeholder base in any other professional organization or trade association here within the healthcare industry. So how does PQA serve these members, and what roles does PQA have in the industry? Let's look at our next slide here, where we will find 4 of them nicely summarized here in 4 different boxes. So PQA is a measure developer, a quality educator, a researcher, and a convener. PQA is most nationally recognized as a measure developer with our medication use measures for medication safety, adherence, and appropriate use. I'll let Ben speak to the gory details of the consensus-driven process that we use to draft, test, refine, and endorse our measures. As a quality educator, PQA is promoting the use and impact of our measures, as well as other healthcare quality topics. This is being done through a number of different forums and avenues, one of which is our quality forum workshops and webinars, as well as a number of different member education offerings, academic education, and education that we offer to patients. Oftentimes, this content is showcased at our PQA annual meeting in May, as well as the Leadership Summit in November. As a researcher, PQA is informing new measure development, showing the value of measures, and promoting best practices with a team dedicating themselves to a number of different research and demonstration projects. And finally, as a convener, PQA is fostering relationships with diverse stakeholders to advance shared goals. We just discussed our multi-stakeholder membership, and PQA takes very seriously bringing together diverse stakeholders at roundtables, collaborations, and task forces. We also bring together these relationships and foster them through networking at the annual meeting and Leadership Summit. So in summary, PQA has 4 different roles as a measure developer, quality educator, researcher, and convener. At this point, I'll hand it over to Ben to again speak to the gory details of PQA's measure development process.
Thanks, Lauren. You've provided a fantastic overview of PQA for us here. So let's take this opportunity to dive a little bit deeper into our measure development work. As Lauren mentioned, PQA employs a transparent, consensus-based process to draft, test, refine, endorse, and maintain our quality measures such that they accurately reflect the quality of health plans and pharmacies. So as I said, at PQA, we really pride ourselves on using a systematic and consensus-based measure development process that takes a measure from simply being a concept or an idea all the way through the process to a measure that is ready for prime time and ready for use in programs. PQA's process combines the best practices laid out in the CMS Meaningful Measures Blueprint with additional transparency provided by a consensus-based organization. The first stage in the measure development process is conceptualization, where we identify and prioritize concepts to be developed. So this can be through activities like environmental scanning, through literature reviews, or through recommendations and advice from one of PQA's many panels that we bring together to help us identify existing gaps and priorities. The second stage, specification, is where we translate a measurement concept into the language of measurements, into a numerator and denominator and all the other associated technical definitions, codes, NDCs, and logic. This is where the idea of adherence to statins truly becomes a technical definition, like the proportion of individuals 18 years of older with a proportion of days covered threshold of greater than 80%, excluding individuals in hospice and with end-stage renal disease, meeting continuous enrollment criteria, et cetera, et cetera. So once we have a firm specification, we'll focus on testing by applying our specifications to representative sample data. Some of the questions we'll look to answer during testing are, how many people are being drawn into this measure? How many people are meeting the numerator criteria? Are the exclusions impacting as many people as we expected? Is the measure statistically reliable? Is it empirically valid and linked to the outcomes of interest to us? So things like this really help us understand how a measure will actually function once it's out and used in the field and in the marketplace. Once a measure is tested and approved by internal PQA staff, as well as the Quality Metrics Expert Panel, which is a standing body of measurement experts here at PQA, that measure will then move to membership for an endorsement vote from all members of PQA. And this really is an important part of the consensus-based process. This really sort of shows the extent to which these measures are vetted by a diverse body of stakeholder groups to ensure that these measures are ready to be used out in the marketplace to drive quality and accountability in various programs. Finally, as Lauren has heard me say, I like to say that there's no such thing as a finished measure. And the road really doesn't end with endorsement at PQA. We devote a lot of resources to maintaining our measures, which means understanding how the measure is used in the field, keeping abreast of changing guidelines and indications for drugs, listening carefully to feedback and technical assistance requests when our logic may be unclear, and really just ensuring that over time our measures stay relevant, robust, and evidence-based. And this is something that PQA takes a lot of pride in, is the extent to which we are a very engaged and dedicated steward of our measures. One of the fundamental aspects of PQA's process is our standard measurement criteria that help us to systematically assess and evaluate quality measures. The four sort of primary evaluation criteria we use are importance, which is the extent to which a measure is focused on a priority area, meets a need, and is truly evidence-based. Scientific acceptability, which sort of captures the extent to which, once implemented, a measure will produce consistent, reliable, and credible, valid results about the quality of care. So just to speak to that a little bit, we do typically think of scientific acceptability as reliability, which again is the ability to get the same result over and over, or put another way, the extent to which differences in performance are really attributable to differences in quality rather than statistical noise. And validity, which you can really just think of as, is this really capturing what we're trying to capture? Beyond scientific acceptability, we also look at feasibility. So feasibility is going to be the extent to which a measure, once specified, is actually able to be implemented. So if logic is too complex, if the data required are not standardized or are not interoperable or able to be exchanged between reporting entities and programs, then a measure may not be feasible. It may be a good idea, but it may just not work. So that's a very important criterion to consider. And then finally, we also look at usability. So usability looks at if it is meeting all of these other, important criteria, is there a space for it in the marketplace? Is there a program in which it can be implemented and drive that improvement? So, measures are great, but they need a home at the end of the day. They need a program in which they can be used to hold entities accountable and to drive quality for patients and for the health system. As mentioned previously, PQA does bucket our measures into four categories. We develop and steward adherence measures, which many folks may be most familiar with. These are quite prominent in the Part D STARS program and in other programs. We typically use a proportion of days covered methodology to assess adherence for a variety of medications and disease states. We also look at appropriate use. So this is often sort of gap-filling style measures, such as statin use in persons with diabetes, or one of our newer measures, international normalized ratio monitoring for individuals on warfarin. So another sort of looking at, is a gap filled? Is a service occurring, or a prescription or test or monitoring occurring when it needs to be? We also have a safety bucket, and this is where our measures related to drug-drug interactions or DDIs live. We have a number of polypharmacy-related measures, use of high-risk medications in the elderly. Notably, and I'll speak to this on the next slide, this is also where our opioid measures live. PQA is very active in the opioid space, and those are some of our most impactful and widely adopted measures. And finally, we do also have some number of measures like the CMR measure that Chris spoke to earlier that relate to medication management services and medication therapy management. So to speak a little bit to the PQA opioid measure set, this really is one of PQA's focus areas and one of the spaces where we've been most impactful. PQA's opioid measures really target a variety of prescribing behaviors and monitoring sort of measures, everything from high dose to initial duration to concurrent prescribing of opioids and benzodiazepines to annual monitoring for persons on long-term opioid therapy. And these measures can be seen in use in a variety of programs, ranging from the CMS Part D program to the individual market quality rating system to the Medicaid child and adult core set, even to individual state-level quality and accountability programs. So these metrics really are sort of a set that provide critical information to our healthcare system as a whole as we continue to work to combat the opioid epidemic. So one thing that we do like to point out is that PQA's measures and quality measures in general really do a lot more than just influence provider payments or incentivize plans to try to move the needle on a dashboard somewhere. Quality measures and PQA's measures specifically have real downstream impacts for our healthcare system. In 2018, CMS conducted an impact assessment for the Part D program and quality measures within that program, looking at data from 2011 to 2015 to see if this hypothesis that robust quality measurement would actually drive improved care and reduced costs. And the result was that it was a resounding success. Looking at PDC's 3-rate adherence measure, which uses the proportion of days covered methodology to focus on diabetes, statin, and RASA, or renin-angiotensin system antagonist adherence, the results from that evaluation were quite remarkable. Over that time period, from 2011 to 2015, PQA's measures resulted in 5 million additional adherent patients and between 4 and nearly 27 billion in cost savings. This really is a testament to the effect that quality measurement and value-based care can have, both on patient care and on that costs that our health system incurs. Many more research studies conducted based on PQA's measures have further fleshed out and demonstrated and quantified the relationship between PQA measures and improved outcomes and reduced costs. In short, the data here are clear. Quality makes a difference, and measurement is the backbone of quality. So we do provide references here for you all to explore on your own, but with that, I will pass it back to Chris.
Thanks, Ben and Lauren. And thank you all for joining us for this presentation on medication use quality and the impacts that it has on healthcare system quality as a whole. We do hope that you found this information informative and that you can take some of it with you to apply back to your practice as well. If you do have additional questions, certainly reach out to us at education@pqaalliance.org. And if you do desire additional information on any of our 4 pillars and the current projects and processes that we're working through, see our website at pqaalliance.org. At this time, I would encourage you to go ahead and complete the assessment questions that are provided separately within the CE system here. And finally, again, we hope that you do enjoy the rest of the conference while you're attending.